Today, we are going to discuss the stepwise clinical examination of varicose veins, focusing on the important examination findings, diagnostic reasoning, and underlying venous pathophysiology. Varicose veins are dilated, tortuous, elongated superficial veins that develop because of chronic venous insufficiency and valve incompetence. They most commonly involve the superficial venous system of the lower limbs, especially the great saphenous vein and small saphenous vein systems. A proper clinical examination is extremely important because it not only confirms the diagnosis, but also helps identify the site of venous incompetence, assess disease severity, and detect complications such as ulcers or thrombophlebitis. The examination should always be systematic and performed step by step. The first stage begins with initial inspection and general assessment. The patient should always be examined in the standing position because gravity increases venous filling and makes varicosities more visible. Both lower limbs are inspected from the front, back, and medial aspects. During inspection, we first observe the morphology and distribution of the dilated veins. We assess whether the varicosities are long, tortuous, localized, diffuse, or involving the great saphenous vein territory or small saphenous vein territory. The great saphenous vein runs along the medial side of the leg and thigh and drains into the femoral vein at the saphenofemoral junction near the groin. The small saphenous vein runs along the posterior aspect of the calf and drains into the popliteal vein at the saphenopopliteal junction behind the knee. Identifying the pattern of varicosities helps localize the underlying venous incompetence. Next, we carefully examine for skin changes associated with chronic venous hypertension. Long-standing venous insufficiency causes increased venous pressure, leading to leakage of fluid and red blood cells into surrounding tissues. As hemoglobin breaks down, hemosiderin deposition causes brownish hyperpigmentation, especially around the gaiter region near the ankle. The skin may become thickened and fibrotic, a condition known as lipodermatosclerosis. Eczema, dryness, and venous dermatitis may also be present. These findings indicate chronic venous disease and prolonged venous hypertension. We also assess for edema, particularly around the ankle and lower leg. Venous edema develops because elevated venous pressure pushes fluid from the vascular compartment into surrounding tissues. The degree of swelling provides insight into the severity of venous insufficiency. After inspection, the examination proceeds to functional maneuvers, which help determine valve competence and deep venous patency. One of the classical bedside tests is the Trendelenburg test. In this test, the patient lies down and the leg is elevated to empty superficial veins. A tourniquet is then applied near the upper thigh to compress superficial venous flow, particularly at the saphenofemoral junction. The patient is then asked to stand while the examiner observes venous filling. If the veins remain collapsed initially and rapidly fill after releasing the tourniquet, this suggests incompetence at the saphenofemoral junction. However, if veins fill rapidly, even before releasing the tourniquet, perforator vein incompetence is likely present. The reasoning behind this test is based on retrograde venous flow due to incompetent valves. Normally, venous valves prevent backward flow of blood, but in varicose veins these valves fail, allowing reflux and venous pooling. Another important bedside maneuver is the Perthes test, which evaluates the deep venous system and perforator vein patency. In this test, a tourniquet is applied while the patient walks or performs calf muscle contractions. If the superficial varicosities empty during walking, it indicates that the deep venous system is patent and functioning normally because muscular contraction pushes blood into deep veins effectively. However, if the veins become more distended and painful, this may suggest deep vein obstruction or incompetent perforator veins. This test is important because treatment planning differs significantly if deep venous disease coexists with superficial venous insufficiency. The image also highlights the underlying diagnostic anatomy and pathophysiology of varicose veins. The great saphenous vein and small saphenous vein form the major superficial venous systems of the lower limb. Blood normally flows upward toward the heart with the help of competent venous valves and calf muscle pumping action. In chronic venous insufficiency, These valves become incompetent, allowing blood to reflux backward under gravitational pressure. This leads to venous dilation, tortuosity, venous hypertension, edema, skin changes, and eventually ulceration. The saphenophumeral junction and saphenophopleural junction are common sites of valve incompetence, and identifying involvement of these junctions is crucial during examination and surgical planning. Next, we assess for associated findings and complications of chronic venous insufficiency. One of the most important complications is venous ulceration, especially around the gaiter region near the medial malleolus. Venous ulcers are usually shallow, irregular, and associated with surrounding hyperpigmentation and edema. Their presence indicates advanced chronic venous disease. We also examine for thrombophlebitis, which refers to inflammation and thrombosis within superficial veins. The affected vein may appear red, tender, warm, and cord-like on palpation. Superficial thrombophlebitis can occasionally extend into deeper veins, increasing the risk of deep vein thrombosis. Another associated finding includes telangiectasias or spider veins, which are smaller superficial dilated vessels often seen around varicose territories. Evidence of recent bleeding from fragile superficial veins should also be noted because varicose veins can rupture following minor trauma. Finally, the examination concludes with diagnostic interpretation and clinical correlation. We summarize whether the disease mainly involves the great saphenous system or small saphenous system, whether valve incompetence is present at the saphenophumeral or saphenophopleural junctions, and whether perforator incompetence exists. We also document the severity of skin changes, edema, ulceration, or thrombophlebitis. A detailed history is equally important and should include prolonged standing occupations, family history, obesity, pregnancy, previous deep vein thrombosis, or prior venous surgery. Combining the clinical findings with bedside functional tests allows the clinician to diagnose chronic venous insufficiency accurately and identify the underlying venous pathology. To summarize, the clinical examination of varicose veins is a structured and systematic process beginning with standing inspection, followed by assessment of vein distribution, skin changes, edema, and functional maneuvers such as the Trendelenburg and Perthes tests. The examination aims to identify venous reflux, valve incompetence, deep venous patency, and complications of chronic venous hypertension. Key diagnostic clues include visible tortuous veins, skin pigmentation, edema, positive Trendelenburg findings, and evidence of chronic venous insufficiency. A thorough clinical examination remains the foundation for diagnosis and guides further evaluation, with Doppler ultrasound and definitive management planning.